So today, now we all know that the ERPM format has changed, right? So basically, what they have done is they have told everybody that format is changing, and they have given the number of stations that every total number of stations they have published. Apart from that, I think they have not published any data about what type of stations they are going to be. All right, only we know how much per each subject there will be stations, right? Am I correct? Yeah. So I'm not sure whether they will publish any information soon, or they might sometimes they might publish near the exam. We are not very sure about that. So what we can do is, like now these type of OSCEs, the PLAB exam also used to have OSCEs like this, right? Now the PLAB is also not there, but the PLAB also had OSCEs, right? So when you talk about OSCEs, it's kind of different from the VIVA, right? In the VIVA, basically is a long term, like for example, for our long case, there was like 20 minutes. So there was long time for you to interact with the patient and go for discussion, right? But in OSCE, there is not much time, right? So for example, in the OSCE, like if you calculate the time periods for each station, there will be around 10 minutes, right? So in the sample, now what we can expect in OSCE, we can expect different kind of scenarios, right? For example, we can expect the patient, we can expect to get a procedure, right? For example, applying a simple suturing, right? Or putting an NG tube, right? Or like that small procedures we can expect in the OSCE, right? Apart from that, we can expect something like communication, right? So basically communicating with the patient or communicating with the peer, right? So what do you mean by that? Means we basically, for example, think that you are having a patient, you have a referral, you want to inform that referral to somebody, right? For example, think a dermatology referral, right? How to inform dermatologist, or think like some case like you are having a patient, critical patient, your consultant has asked to get an ICU booking, right? So you are going to go to the consultant anesthetist in the ICU and ask for ICU bed. So that's called conveying information to a peer, right? So communication could be between you and a patient or you and a peer. So those you can expect, right? Apart from that, also you can expect things like communicate, like kind of a long case, like basically patient coming with his complaints, with a complaint of, like, for example, we'll take the today's case scenario, abdominal pain. You are told to take a history and address to the patient's questions and concerns, right? So most of this time there would be discussion between you and in this history taking is only 10 minutes, right? So most of the time there would be a discussion between you and the examiner. Even if there was an examiner discussion, it would be a very short one, right? Remember that now in OSCE, they are not assessing your knowledge, right? Your knowledge has already been assessed in your MCQ. Now what they're assessing is basically your data gathering skills, your technical skills, that means your practical and technical skills, whether you can do any practical procedures and all, and patient assessment skills. So those are things that they focus on mainly. Apart from that, they will assess you like clinical management, such as formulating a what do you call management plan, right? Formulating a basis investigation and management plan and explaining that to the patient, right? And apart from that, as I said earlier, interpersonal skills, basically whether how do you interact with the patient as well as how do you interact with the peer of yours, right? Apart from that, you might also get something like interpreting an investigation. For example, they can give you an X-ray and ask you to just comment about it, right? Give you an full blood count, give you a liver profile, right? And to elaborate on that and come to a diagnosis, right? And if the time permits, then maybe they will go into a small discussion of how to investigate further and how to manage furthermore, right? And also they can give you other, another thing that you can expect is doing simple medical duties that the HO is supposed to do, right? So what are those? Such as form fillings, right? So when you are going to be a medical officer, house officer, you will be in charge of filling all these investigation forms, right? For example, this ultrasound scan, MRI, CCT, blood investigations, and everything, right? So they can give you this investigation form and ask you to fill based on a given skin. They will give you some patient details, and based on that they will ask you to fill a form, right? Or write a referral, right? For example, imagine you are having a patient, as we said earlier, with think of some scabies or something. So you are a medical house officer, so you are going to put a referral to the dermatology team, right? So basically, how you write a referral to the dermatology team, right? Or any other situation, right? So medical duties like form filling or referral writing. So these things you can expect in your OSCE. Since they have not published a guideline, we can only suspect, right? And as I said again, communication with a peer or a patient. Or we can also expect things like critical care patient discussion. For example, patient with sepsis, patient with trauma, like in your emergency VIVA, like the previous time there was an emergency VIVA, right? So based on the emergency case, discuss, you are given a patient case scenario, and you will be asked how you investigate and how you assess and how you manage, right? So these are the things. These are some of the areas that can be suspected to come in your OSCE, right? Unfortunately, you guys have become the first group to sit this examination, so you are kind of like a guinea pigs, right? So that is a little bit unfortunate, right? But only we will get to know what kind of exam this is, unless they publish a guideline very soon, right? Talking about the SLMC, we are not very sure about what will happen, but we'll expect what to come based on other OSCEs like lab exam, for example, the part 1 MD surgery exam, like that. We have those OSCEs. What do they expect in OSCEs? We'll just use in here also, right? And based on this, we'll do some set of classes to get you up to the standards, right? So history taking is a must, right? It will definitely come, no doubt there, right? You will be given a patient, you will be there to interact with the patient and take a history, and sometimes even examinations, right? You won't be able to examine and take a history both in the same patient, because 10 minutes is not a big time, but at least either history or examination, one of those will definitely come. Apart from that, something from which I mentioned might also come, right? So that is basically the type of thing we are going to expect, right? Okay, so today, based on that, I thought of discussing about abdominal pain. So in surgery, abdominal pain is a very common scenario, right? So it is a long case in the past exam, right? Abdominal pain can be going into various directions, right? So for example, in the abdomen, if you divide it into 9 quadrants, 9 to 9 segments, based on that, there is limitless things that you can get, right? You can get septic ulceration, biliary colic, gastric cancer, any appendicitis, anything, right? So today I thought about discussing abdominal pain, mainly focusing about biliary colic, but we also discuss about other, mainly focusing on biliary colic, but also on the other aspects also, right? Okay, so let's go to our case today. So this is a in this station, can you see the screen? Okay, so this is a Word document, so I don't know how to. Okay, so yeah, So this is a station. Basically, there's a patient waiting you in the room, and his complaint is abdominal pain, right? So you are the surgical house officer in a hospital, and you are supposed to interact with this patient, gather the patient's history, and then go on to explain the diagnosis to this patient, explain your suspected diagnosis to the patient, answer the questions the patient is having, and then formulate an investigation plan and a management plan, and explain that to the patient in basic layman's term, right? So these are your tasks in this OSCE station. Did you understand? Okay. So let's have a little bit. So this is a 45-year-old female. So this is the presentation that you get. You might get a small piece of paper saying this. So Tushari Fernando, 45-year-old woman, present with intermittent right upper quadrant abdominal pain for the past 3 months. Pain typically follows fatty meals, lasts for 30 to 60 minutes, and resolves spontaneously. She has no fever, vomiting, or jaundice. She has no history of abdominal surgeries, and abdominal ultrasound shows multiple gallstones within the gallbladder with no evidence of cholecystitis and biliary obstruction or dilated ducts. Now remember, in a proper OSCE station, you won't get this ultrasound scan, right? Because that basically gives up the diagnosis, right? So we'll erase that. That won't be there, right? So based on this, you are supposed to talk to this patient, right? And take a furthermore detailed history to come to a diagnosis, right? Now based on these few what do you call information, you have a rough idea of what this patient is having, right? It could be a biliary colic or acute cholecystitis, but he is not having pain, so most likely a biliary colic, right? Okay. So you have 10 minutes, take a focus history, explain the diagnosis, do the relevant investigations, and clearly explain to that patient, right? And these are the questions the patient is having, right? Role play. Now, these also you won't be seeing in the exam. Role play instructions you won't be getting. That is for the role player. Basically, the patient that is playing the role of. So they only. So just for your sake, we have added it. So they are told to ask you these questions. Why do I keep getting this pain? So basically, they are asking why this pain is happening to me. What is happening to me, right? And then after explaining, she's going to ask you, do I need surgery, right? So now then she is going to ask, what happens if I don't treat it? If I don't go for surgery, what will happen to me, right? And if I go for surgery, how long will I stay in the hospital? And the biggest question every patient is having, is it cancer, right? So these 5 questions the patient is going to ask you. So you have to explain to them in layman's term, in empathetical way, that the condition of the patient, right? Okay. So let's go into the discussion. We'll take this off. Okay. Can you see my slide presentation? Okay. So as I mentioned, these are these things we'll skip, right? So as I said earlier, the probable OSCE station that you will get, right? Okay. So let's dive into our case scenario, right? Okay. So when you come face to face with the patient, what will you first do? Now, if you meet somebody in the road, what will you first do? Shankar, what are you going to do?
So greet and introduce.
Yeah. So you are basically you are going to say hello, good morning, right? And tell who you are, right? Because she doesn't know you. You are going to tell, I'm Dr. Shankar, I'm the house officer in this ward. And you clarify the credentials of this patient. You don't know whether this is the patient or somebody else. This could be the patient's bystander. And you clarify the patient's credentials. Are you Mrs. Tushari Fernando? Now we said the patient's name is Tushari Fernando. Are you Mrs. Tushari Fernando, and how old are you? Right? So basically introduce yourself and clarify the credentials. Okay. So then you ask the patient, now we want to get to the presenting complaint, right? So what is the presenting complaint? Can anybody tell me what is the presenting complaint? So presenting complaint is basically the problem she's coming to see you now. The problem that she is having now, for which she's coming to say, have a look. For this patient, it is abdominal pain, right? There may be associated other symptoms, but at the moment she's having abdominal pain. For that only she's coming, right? So we ask, why are you? So what brings you to us today, right? So basically it's an open question. So basically patient can say, what is problem, right? Now this is a artificial scenario, right? This is not a real scenario, right? In real scenario, patients will not directly say a presenting complaint. They will say a set of complaints. But in this is a role playing. So this role player will be asked to tell you the one single law, few complaints in which she highlights the presenting complaint, right? So it's easier for you in this role play situation rather than in a real world, right? So when you ask that, patient will say, oh doctor, I have been having this abdominal pain for the last 3 months, and it is very severe sometimes. I can't even bear it sometimes. Usually it's they like from there she might stop, right? So you basically got your presenting complaint now. So presenting complaint is the first major part of your history taking, right? And then comes the analyzing the presenting complaint, right? So now this patient is having pain, right? How do you analyze the pain? Anybody knows?
Socrates.
Yeah, you have this mnemonic called Socrates, right? But before you go into the Socrates and analyze everything, you must make sure one thing. Can anybody tell me what is the patient in a state to answer your questions, right? Now, if the patient is in pain, she's coming to you with abdominal pain, and she's in pain, she might not be able to focus on your questions, right? And she might be answering she might not be on answering, right? So because of that, you should confirm that have we given something for this pain? If not, what can we give something for this pain? Most in this role playing scenario, because we need to continue this discussion. When you ask this question from the patient, yes doctor, the OPD doctor gave me some medications, and then when you ask you, okay, how is the pain now? Doctor, now the pain is settled, right? Because we need to continue this discussion. So once you clarify that, only you know this patient is not in pain, right? So it's only logical that we ask it, right? So basically ask that, right? Oh, after that, we can dive into our analyzing the presenting complaint. Okay. So you can ask, okay, then shall we discuss a bit more about your abdominal pain? And then when she says yes, okay, can you tell me where this pain is localized? Can we show on your abdomen where this pain is most, right? If it's a diffuse pain, she will tell all over the abdomen. If it is not a diffuse pain, she will say, doctor, is usually in the upper part of the abdomen, right? Upper left, right side of my abdomen. That is the site, right? Then the onset. Socrates again, onset. So onset, what is the onset? So whether this starts out of nowhere, rapid, sudden onset of a pain, right? Or whether it is a gradual onset kind of a pain, right? And also when it started, right? How did it start originally? Now she's been telling she's having pain for 3 months, right? When did it start first? Over this time of 3 months, how was it? Was it pain progressively getting worse, or does it respond to analgesics and all, right? And then the character, what kind of characteristic pain is there, right? It could be a dull pain, sharp pain, colicky pain, compressive pain, cramping, burning, or it could be constant or intermittent pain, right? So by telling just dull, sharp colic, patient might not understand. So we should have our words pre-prepared, right? Basically, dull. Dull means මොන හරි වාට පද කරලා දැන පද කරන් ඉන්නා වගේ කැක්කුමක් දෙන්න. Sharp pain නිකන් මොකද කැපෙනවා නිකන් අයිනවා වගේ කැක්කුමක් දෙන්න. colicky pain කැක්කුම එනවා යනවා තද වෙනවා යනවා ඒ වගේ කැක්කුමක් දෙන්න. compressive as I said again පද කරනවා. cramping නිකන් කොර වෙලා යනවා කැක්කුමක් දෙන්න. burning නිකන් බඩ ඇතුලෙන් නිකන් පිච්චිලා යනවා වගේ නිකන් දනවා වගේ කැක්කුමක් දෙන්න. right? So you should have these questions pre-planned. Basically, when you are now you will be going for hospitals to practice, right? So when you go, you should pre-plan these questions and ask this question from the patient and keep these questions like in the tips of the fingers, right? So basically, it should come without the effort, right? And then once we have get the character of the pain, we go to the radiation. So radiation is also very important. With the radiation, we can identify different types of pains, the origin of the pain, right? For example, now we are talking about the biliary colic. Biliary colic usually is not radiating anywhere, but if it is acute cholecystitis, would it radiate? Yes, right? It is going to radiate into the right tip of the scapula, right? So that's called. So we should ask for this radiation. That is the R. So A, association. So what are the other associated symptoms with this, right? For example, when you talk about biliary colic, we will be associated with others such as autonomic symptoms, nausea and vomiting, right? May associated with the pain, right? And if it's a think about any other case of malignancy, the patient will be having loss of appetite, loss of weight, right? Imagine it's a low abdominal pain like appendicitis or any gynecological problems. The patient might have dysuria, diarrhea, menstrual symptoms, right? And if it's a pathology in the stomach, right? Patient could be associated with dyspepsia, right? So all these things associated. Now we don't go ask everything about this, right? Based on the site of this pain, we focus our questions, right? For example, if we think the patient is coming with RIF pain and this looks like appendicitis, we ask questions that is relevant to appendicitis and other differential diagnosis, right? So example, dysuria, diarrhea, menstrual symptoms and all, right? Okay, that is associated symptoms. And the timing, course of progression of pain, whether it's continuous and linear. I think we asked it early in the onset also, but you can either ask it onset or here, doesn't matter, doesn't make a difference, right? And exacerbating and relieving factors. So what caused this pain? Now in this patient, if you remember, she tells usually the pain starts when she eat food, right? So biliary colic also, these patients might get in the night. Usually they wake up in the night with severe pain. And when they wake up, sometimes the stone gets dislodged from the neck of the gallbladder and the pain reduces, right? So exacerbating and relieving factors. What does it relieve, right? Does the rest relieve? Do you need to take some medications? Does it relieve with changing the position, right? All these things. And the severity. Now, severity is so very important, right? Whether this is affecting your day-to-day activities and your sleep. Now, imagine there's a pain that is affecting your sleep. That is severe. That is a severe pain. But you have a pain that does not affect your sleep. That means that pain is not very severe. Now, imagine you are having a severe pain. Basically, you can't sleep. You will be howling in pain rather than sleeping. The patient is able to sleep. That means the pain is not that problematic, right? And the severity. Now imagine this is a chronic pancreatitis kind of history. Then the severity is very important. Whether imagine it's a small child, whether this child's going to school is affected. If it's an adult, whether his day-to-day activities, his job is affected, right? All these things also should be encompassed in severity, right? If you didn't ask it here, at least you should ask in the complications, right? If you forget to ask it here, at least you should ask in the complications. So basically, this is how you analyze the abdominal. Any kind of pain you can analyze like this, right? Socrates model, right? And after this analyzing the presenting complaint, if you have any other associated complaints, you can if you have time or if you think that is relevant, you can just dig on those associated complaints as well, right? Okay. So
associated complaints කියන්නේ වෙන මොනවත් අමාරු තියනවා වගේද?
yeah, now I said earlier, now in this slideshow, now associate other pains like dysuria, menstrual symptom, diarrhea and all. You can elaborate on that also if you want. Like when do you get menstrual symptoms? Like when do you get dysuria? Whether it's like like whether she is having this throughout or like intermittently, like that. If you think that is relevant, you can dig into these associated symptoms and go on little bit furthermore on that also. For example, loss of appetite, loss of weight, what came first? If the patient has jaundice, what came first, right? Jaundice, pruritus, and what came first, right? So all these things might be if you think is relevant, you can ask about it, right? Okay. So yeah, when you talk about pain, if it's constant pain, it's usually something like inflammatory and neoplastic, right? And if it is a colicky type of pain, usually these are the two types of pain that in biliary colic, right? Either colicky pain or constant pain, right? Colicky pain is like basically it comes and goes. You might remember in the theory days, like when something is blocked, what happens is we try to pressure it out, right? So that is when the colic is happening. Basically, peristalsis or whatever tries to get rid of the obstruction, and then the colicky pain comes. But the interesting thing about the biliary tract is this colicky pain never comes to the baseline like in the gastrointestinal tract. So it is type of a colicky pain, but it never comes to the baseline itself. But in abdomen, like bowels, for example, bowel obstruction, this colic pain comes back to the baseline and then starts again, right? So this is especially biliary and renal colic, right? Okay. Now we have analyzed the presenting complaint and associated complaints, right? Now we are going to, now we have a complaint. Now we have to come to a diagnosis. To come to a diagnosis, we can't just come into one diagnosis. There will be a set of differential diagnoses. Out of that, out of all of them, what is the most suitable becomes the most likely diagnosis, right? So when you talk about differential diagnosis in abdomen, you always separate the abdomen into 9 quadrants. Then it's very easy for you, right? And depending on the site of the pain that patient is talking about, our differential diagnosis questions are going to be focused. Now, in a 10 minutes time, we can't be asking all the questions for all the quadrants, right? So that will take a lot of time, and by the time the bell rings, we won't be able to touch the complications, right? Because so that we focus our history depending on our analyzation of the presenting complaint. She told about something about the site, character, radiation. She told us. Based on that, we focus on. Now, example. Now she told us about right upper quadrant pain, right? So when you talk about right upper quadrant pain, the differential diagnosis that you are going to get is it could be either biliary colic or acute cholecystitis or acute cholangitis, right? Or something like a malignancy, dull pain causing like a malignancy such as hypercholangiocarcinoma or head of pancreas cancer, right? Or it could be a duodenal ulcer, right? Okay, so these are the few differential diagnoses that should come to a head. Imagine the patient told the abdominal pain on the epigastrium, right? So what are the things that in the epigastrium that can cause pain? Again, the stomach is there, right? So gastritis and peptic ulcerations and gastric cancer, all three from the stomach. And there's a part of the esophagus also, right? So you know that GORD can come as heartburn, right? Heartburn also patient can come and tell you about as what you call epigastric pain. And also remember that even is myocardial infarction also can come as epigastric pain, right? So you should you should ask a few details about that also to show that you are not thinking just about surgery, but you are thinking of the patient as a whole, right? If the patient is talking about epigastric pain, right? And also there's the pancreas. It could be acute pancreatitis, it could be chronic pancreatitis, it could be pancreatic cancer, right? And then we have the flanks and the umbilical region, and as well as the left and right iliac fossa. Depending on the region, what our differential diagnosis are different. What are the organs that are involved? If we think about the organ that is involved, then we can think about what are the questions we are going to ask to do a differential diagnosis, right? Okay. So you can see in this image the 9 segments and what are the likely organs that are involved in the 9 segments, right? So as we all know, in the RIF is the appendix, cecum, and the adnexia, right? In the left iliac fossa, it's again sigmoid colon, and sometimes the adnexia also can. In the flanks is the kidneys, right? In the center region is usually the small bowel, right? Small bowel and retroperitoneal structures, right? Okay. And the suprapubic region obviously the bladder, right? Bladder and the other uterus and other adnexial regions. So based on the differential diagnosis, for differential diagnosis, we'll discuss a little bit of a differential diagnosis because we are covering the intra-abdominal pain in this. We'll discuss a bit also. So in the epigastric region, what we are having is the first diagnosis would be one of the first diagnosis esophagitis, right? So basically, why the esophagitis? It could be due to gastric esophageal reflux disease, right? So how do you ask of them? Basically, whether the patient is getting reflux symptoms such as heartburn, right? Usually when the patient is lying down, the patient gets these symptoms worsened, right? Because the gravity is eliminated, now the acid is freely refluxing into the esophagus, right? Bitter taste in the mouth when the patient arises because of the acid is very bitter. When it refluxes and all, it will accumulate in the mouth and it goes bitter, right? Ear pain, dental caries, right? Early morning hoarse voice because of the gastric acid will reflux into vocal cords and cause hoarse voice, right? And we should also ask about the red flags such as dysphagia, right? To exclude that whether this could be a esophageal malignancy, right? You should also exclude the red flags also, right? Okay, and peptic ulcer disease. Now we have then we come peptic ulcer disease, right? So peptic ulcer disease, there could be either gastric ulcers or duodenal ulcers, right? So depending on whether it's gastric or duodenal, the presentation is going to differ. No, as you all know, gastric ulcer is famous for pain after eating food. The pain will be worsened after eating foods, and the pain will be increased. Pain, and the patient will be in fear of eating, right? So it's the other way around, right? So a patient will be in fear of eating foods, right? And the patient will be having other dyspeptic symptoms such as bloating, like epigastric pain, heartburn, and all of those, right? And when it comes to duodenal ulcers, it's the other way around. Basically, the pain reduces when you eat food, right? So the patient will be having pain when at the night, at fasting at night and during the night periods, he will wake up with dyspeptic kind of pain, right? And because of this excessive weight, the patient will be gaining weight also, right? So those few subtle questions can give you an idea about what the differential diagnosis are, right? And you can also ask about complications of the hematemesis melina, right? So you know when you have gastric ulceration, there could be bleeding, right? It could come out as either coffee ground bleeding or just plain red colored bleeding or melina because it's upper GI bleeding, right? And etiology you can ask here or you can ask in the etiology segment. It is as your preference, right? Such as etiology such as NSAIDs, aspirin, stress, psychological stress, obesity, smoking, alcohol, all of these are risk factors, right? So you can ask this here or in the etiology. That's up to you, right? And as I mentioned again, the myocardial infarction symptoms also we should ask, right? Whether there's associated pain in the right arm, associated with nausea and vomiting and sweating, right? Palpitations, syncope, those associated syncope. So all of these also should be asked to exclude myocardial infarction. So that shows the examiner that you are not just focusing on the abdomen, but as a patient as a whole, right? So that gives you more credibility and marks. Okay. Okay. So that's the epigastric. And again, perforated peptic ulcer. Now we talk about gastric ulcers, but perforated peptic ulcers, the symptoms are very different. The pain is basically pain starts like sudden onset pain, and this is a very severe type of pain. And the patient will be in extreme excruciating pain, and patient won't be able to mobile, right? And even small acts like respiration is painful. Patient is immobile, basically still. Patient is not moving because moving will cause pain, right? And also we have this gastric cancer, right? So associated with dyspeptic pain, epigastric constant mild pain, loss of appetite, loss of weight, early satiety, and depending on where the lesion is, either the proximal region of the stomach or the distal region near the pyloric region, patient might have dysphagia or gastric outlet obstruction symptoms, right? So basically, you just have to ask a few questions to get to the diagnosis, right? You don't have to keep asking all the now in the theory section, you learned a lot about gastric cancers and its clinical symptoms, right? But there is no time to ask all these symptoms. So you should prioritize which symptoms I'm going to ask to come to the diagnosis, right? So based on these few diagnoses, you can come to a differential diagnosis, right? Okay. And then we have pancreatitis, right? Again, a cause for epigastric pain. So there's acute pancreatitis and chronic pancreatitis. So acute pancreatitis usually acute onset severe pain, which radiates to the back, right? Associated with nausea, vomiting, and it could be associated with alcohol or history of gallstone. If you remember, the mnemonic I get smashed, right? Out of that, the commonest is alcohol and gallstones, right? After that, only rest of the other things come, such as autoimmune, hereditary, scorpion bites, idiopathic infections, drugs and all, right? Scorpion bites and all. So most important is alcohol and history of gallstones. If you ask those two, that's enough. And then chronic. So chronic recurrent episodes of dull pain radiant to the back. This is not acute type of severe pain. It's a chronic dull pain. This pain is not coming to the baseline. The patient is always in pain, right? Depending on the wider cause of pain, the patient may have fluctuation, but patient is always in some kind of a pain. That is in chronic pancreatitis, right? May be associated with meals, associated with weight loss and steatorrhea, features of diabetes in complications, right? So if you ask these things, that will be enough, right? So if you remember, in the theory section, I told causes for pain in pancreatitis, acute chronic pancreatitis, right? So pancreatic cancer is also one of the reasons for chronic pain in pancreatitis, right? So we should ask symptoms such as obstructive jaundice, whether the patient has loss of appetite, loss of weight, right? And other dyspeptic symptoms to exclude the pancreatic carcinoma also. Okay. Next, we will move into our discussion part, the right hypochondrial pains and the differential diagnosis. Yeah, the first of all diagnosis will be biliary colic. Now, what are the commonest people to get biliary colic? There's a five F's, right? Fat, fertile, female, fat, fair, fertile females in their 40s, right? So those are the commonest group of people to get biliary colic. Now, this patient is also fit in that, right? This is a female in the 40s, right? We don't know whether this fat and fair. We have not seen. So we can assume that now, since it's 45, can't comment about the fertility also. But we have things to suspect is biliary colic, right? So we'll first entertain about biliary colic differential diagnosis. So it's a severe type of pain that doesn't come to a baseline, right? So and associated with associated with things like eating fat spicy foods, right? And also associated with the patient having pain in the night time. When the patient go to sleep, patient gets a severe pain, which relieves when the patient stands up, so sits up, right? So, and also we should ask about the patient whether she has previous episodes of jaundice. So this could be biliary colic, and some of these stones could escape into CBD and cause obstruction at some point, right? Or there could be already stones in the CBD. To exclude that, we should ask for jaundice also, because if there are CBD stones, we cannot do a laparoscopic cholecystectomy, right? So if you ask that also, that shows that you are going to talk, you are thinking about the further management also in this patient at that moment, right? And our next other diagnosis, acute cholecystitis, right? Fever, RH, right hypochondrial pain that is radiant to the tip of the scapula, continuous type of pain, and associated nausea and vomiting, right? So these few questions is enough to get you to a groove for diagnosis, right? For get to differential diagnosis. Okay. Chronic cholecystitis, dyspeptic pain associated with food and particularly fatty foods, nausea and vomiting, and postprandial belching, right? And cholangitis, again, very condition with high mortality, right? Fever with chills, jaundice, and severe right hypochondrial continuous pain, right? So jaundice is the key here, right? Jaundice and fever, right? Now this patient is not having any jaundice or fever, so unlike to be a CBD stone or cholangitis, it could be either chronic cholecystitis or it could be acute biliary colic, right? Central abdominal pain. So there we have a lot of diagnosis, right? Acute gastroenteritis, bowel obstruction, small bowel perforations, mesenteric ischemia, inflammatory bowel disease, and remember the mesenteric ischemia also could comes as epigastric pain also, right? It should be a differential diagnosis for epigastric pain also, right? So as you all know, acute gastroenteritis will cause diarrhea and vomiting with cramping abdominal pain, right? And they will be associated outside food intake, right? Something like kottu kava with like egg kava, like something like that, right? And bowel obstruction. So one of the most important diagnoses, right? So what are the features of bowel obstruction? Vomiting, constipation, abdominal distension, and pain. If you ask those three, that is fine, right? But depending on the level of the bowel obstruction, the constipation might be there or not there, right? But again, depending on the level of obstruction, vomiting might be early, vomiting might be late, right? Okay. And small bowel perforation. Again, the patient will be in a peritonitis state, right? Basically, the patient will be immobile and having a sudden severe onset pain, right? With associated fever sometimes. Mesenteric ischemia could be acute or chronic, right? Acute, again, patients with like cramping type of abdominal pain, and it's acute onset, right? But in chronic mesenteric ischemia, usually the pain occurs, cramping type of abdominal pain occurs after eating food, because after eating food, the stomach needs to have a good blood supply. When there's not a good blood supply after eating food, the bowel is going to get into lactic acidosis, right? Due to anaerobic metabolism. So with the peristalsis, so it can cause cramping pain after eating food. That is indicating of chronic mesenteric ischemia. Oh, and inflammatory bowel diseases such as Crohn's disease, ulcerative colitis, right? So Crohn's disease, it mimics the features of appendicitis. Apart and one feature to differentiate from appendicitis is in Crohn's disease, there would be extraintestinal manifestations as well as diarrhea, right? In ulcerative colitis, usually there will be PR bleeding, mucus bleeding, and as well as sometimes if the patient goes in toxic dilatation and distension, those will be also there, right? Okay. Now we will go to the RIF region. So our main diagnosis, the differential diagnosis, the appendicitis, right? Somebody coming with RIF pain, the first thing that goes into us is the appendix inflamed. So what are the type? Fever, migrating type of pain from umbilicus to RIF, nausea, anorexia, and sometimes feature of peritonitis also, like immobile, patient will be immobile, having chills and rigors, severe pain, vomiting, right? Patient may be associated with diarrhea and dysuria, all these things. And Crohn's disease, as I mentioned earlier, and other gynecological pathologies, right? Such as cyst accident, right? Or ectopic pregnancy, things like that. Left iliac fossa. So what are the differential diagnosis of left iliac fossa? Can anybody tell me? Nipuni.
The left side, maybe like if it's a female, ovarian pathologies.
Yes, but this is,
Yeah.
remember, this is a surgical station. So don't go straight to ovarian pathologies, right? So this is surgical station. So you should focus more on surgical pathologies. So what are surgical pathologies? Most
Diverticulitis.
Yes, of course. Sigmoid diverticulitis, one of the commonest cause of abdominal pain in elderly people, right? Sigmoid diverticulitis, good. And then it could be a malignancy, right? Left side or sigmoid colon malignancy, right? It could be a volvulus, sigmoid volvulus, right? It could be, what else? It could be a ulcerative colitis, right? Acute attack of ulcerative colitis, cramping type of abdominal pain with PR bleeding and mucus stools with diarrhea, right? And then you can go to this ovarian pathologies, right? Ovarian and gynecological pathologies, right? And also sometimes ureteric colic also can come as right or left iliac fossa pains, right? So low integument pain can come as kind of a iliac pain. Okay. So sigmoid and left colon cancers, PR bleeding, altered bowel habits, the patient may having bowel obstructive features, right? Constipation, alternating constipation, loss of appetite, loss of weight, mucus stools, right? So these are features of left sigmoid or left colon cancer. Diverticulitis, LIF pain, diarrhea, PR bleeding, bladder fistula causing UTI, fecal urea, pneumaturia, right? And having PR bleeding. So all these are features of diverticulitis. If you ask few of these features differentiate, that is enough, right? So this is how in this OSCE, basically you are acting for the examiners, right? So basically you are acting for the examiners. So the examiner you should show the examiner that you are touching these areas to entertain my differential diagnosis, right? In order to come to a diagnosis, right? Okay, flank pains, the last term, yeah. Obviously the pyelonephritis and renal or ureteric colic, right? So if pyelonephritis, the patient is having severe pain with chills and rigors and associated pain, right? Associated nausea or vomiting, and patient might have dysuria and frequency. In renal colic or ureteric colic, it will be low into type of pain associated with nausea and vomiting, and patient will be having hematuria, right? So those are the few differential diagnoses in flank pain. Okay, now we have entertained all the 9 quadrants, right? So we have come into diagnosis. Now in this patient, what are differential diagnosis? It could be chronic cholecystitis, or it could be biliary colic, right? Okay. So etiology. Now we come to the etiology. Now we analyze the presenting complaint. According to that, we ask some questions and we selected some differential diagnosis. Now we should think why this differential diagnosis occurred. So we are going to go for different etiology, right? So for biliary colics, for biliary colics, there are 3 types of stones, right? Cholesterol stones, pigment stones, and mixed stones. Cholesterol stones is the most common type. So cholesterol stones comes with salimental lifestyle, obese weight, fat-rich diet, right? Consumption of combined, oral contraceptive pills, right? All these things are going to cause cholesterol stones, as well as biliary stasis, such as previous vagotomy. Now, if you remember from the theory days, the reason for biliary cholesterol stone formation is one is stasis, right? And the other is supersaturation and enucleation, right? For stasis, what is the reason for stasis? It could be previous vagotomy, right? You know, for previously for peptic ulcer disease, they used to do selective vagotomy, right? So this vagotomy can denervate the gallbladder and can cause stasis in the gallbladder. So vagotomy. Also, parenteral nutrition is also known to cause what you call gallbladder stone calculi, right? And hemolytic anemias. For the pigment stones, we should ask about history of hemolytic anemia, family history of hemolytic anemia, in any type of hemolytic anemia. So in Sinhala you can ask ලේවල මොනවා හරි ප්‍රශ්න තියෙනවද රතු ලේවල මොනවා හරි ප්‍රශ්න තියෙනවද කියලා. ඒ වගේ you can ask some kind of question, right? So and yeah, so those are the few etiological factors, right? And then we come to complications. Now we have asked the now we have differential diagnosis. In the differential diagnosis, we have asked you for complications. Now when you are talking about biliary colic, the complications are either patient having jaundice because of concomitant CBD stone, or the patient is having associated cholecystitis. So those are the two important complications, right? So you should ask the patient whether the patient had any RHC pain with fever, right? Whether the patient was admitted and given antibiotics, right? For that. And the patient had noticed whether her eyes getting yellow, whether his urine is getting darker, right? Whether the stool is getting paler. So features of obstructive jaundice, right? Okay. And if somehow we are suspecting malignancy such as hydrocholangiocarcinoma also, we should ask for features like loss of appetite, loss of weight, metastatic features like brain, bone, lung and liver. Like brain, we are asking about early morning headache with vomiting, right? And bone, bone pain that is not responding to any analgesics, and even though it responds after the analgesic, it just comes back, right? And lungs, hemoptysis, shortness of breath, right? Liver, again, RHC pain, obstructive jaundice. Yeah, so features of malignancy, right? But in here we don't suspect any of those. We mainly suspect acute biliary colic and cholecystitis, right? So we should trust. So now we talk about lot of these details. Now if we are going to ask all these questions, it will take more than 10 minutes, right? So because of that, we can't do that. So we only focus on, based on our analyzing complaint, we focus our differential diagnosis according to the region. And then we focus our etiology according to our differential diagnosis, and complications also according to our differential diagnosis, right? Now we don't differentiate, we have no suspicion of malignancy, so we don't have to ask for metastatic symptoms, right? Okay. Okay, now we have done with the presenting complaint. So this patient might not be coming to us first, right? The patient could have gone to another doctor and they must have investigated and come to us. Now, if you remember in this examination, in the question, there was somebody has done an ultrasound scan where it shows gallstones, right? So the patient might say, yes, doctor, I went to a doctor. He asked me to do a scan. In the scan, they said there are some stones in my gallbladder, right? So any investigations, any imaging, any interventions, right? Maybe there would been previous CBD stones and ERCP has done, right? Any interventions, something has happened, whether something has done for these problems, right? And then one more important thing is, after taking all this history, you should ask what are the patient's ideas, concerns, and expectations, right? Now this is very important. You can't miss that, right? So basically you should ask, now you have told me everything. Now, do you have any idea about what is happening to you, right? Maybe basically patient already have an idea of what that is. Maybe patient said, I'm not sure, doctor, maybe I'm having some gallstones or stones in the gallbladder, something like that. But in the case of OSCE station, patient might say, no, doctor, I actually have no idea of it, because if she just gives out the answer, then the purpose of OSCE is defeated, right? But she might say, no, doctor, I actually have no idea. Can you please tell me, right? And then we have the concerns of the patient. So what are the patients concerned about? Is this malignant, right? Do I need surgery, right? Can I manage with mega? So those are ideas, concerns, and expectations, right? And expectation, what does the patient want from us, right? So either you can ask it here, or you can ask at the end of the entire history. That is depending on where you would prefer it, right? Nobody's going to penalize whether you ask it here or at the end, right? So, and after now you have asked about, you are going to go to the systematic review and the past medical history. Before going that, you can just put a broad question to the patient. Do you have any other thing regarding your complaint, regarding this pain that I have not asked you? It's a broad question to get anything that maybe I have missed. Do you get the idea? Because in exam situation is very stressful, right? Sometimes you forget stuff, very important stuff you might forget, right? Now, if you put this broad question, sometimes our role player might tell you about that, right? And at the end of the exam also, and questioning also, you should put this question, right? So you can put it here also, you can put it at the end also, right? Okay. Now we are going to systematic review. Now again, the system, when you come to systematic review, we don't go asking all the organs in the body, right? Because that will take time, right? We only ask what is necessary for us. Now imagine this patient is having biliary colic. Now this patient is going to go for undergo laparoscopic cholecystectomy, right? So in that case, we should ask the systematic review to check whether this patient is fit for surgery. That's all, right? So we can ask about the CNS, CVS, respiratory, and hematology. Others are not necessary. GU, GIT, musculoskeletal, right? Psychiatric. Those are not needed, right? Dermatological, not needed, right? We only ask what is necessary for us. Did you understand? So focus on limited time. So we focus on what is necessary. Okay. Then we go to the past medical history. So past medical history, again, now these areas we have to rush fast, right? So we basically ask any other medical problems that you are going for, any clinics, right? Such as diabetes, ischemic heart disease, hypertension, dyslipidemia, right? You can basically ask, what is සීනි තියනවාද, පපු අමාරු තියනවාද, අංශභාගය ඇදලා තියනවාද, පොක්කඩු අමාරු ඇදලා තියනවාද, ප්‍රෙෂර් තියනවාද, කොලෙස්ටරෝල් තියනවාද, like හතිය තියනවාද, like basically we can go run through it, right? If the patient says I have something, right? If the patient I have something, then you can elaborate a little bit on that. For example, the patient says සීනි තියනවා කියලා, right? Then we can ask about macro and microvascular complications. But remember, now when we are asking all these things, we have asked about පපු අමාරු තියනවාද, අංශභාගය තියනවාද, right? So we have asked some of the macrovascular diseases, right? So we have only have to ask the micro, ඇස්පෙනීමේ බොඳවීම ප්‍රශ්න තියනවාද, කකුල දැනෙන්නේ නැද්ද, සෙරිප්පු දෙයක් දාගෙන සෙරිප්පු දෙක ඉබේම ගැලවිලා යනවාද, කකුල වල තුවාල ඇවිල්ලා තියනවාද, හරි නහර බ්ලොක් වෙලා තියෙනවා. So simple questions like that, right? And any hospital admissions and ICU stays, right? So these things you should basically rush. You should not stay, right? Okay. Okay. And then past surgical history. Have you කලින් මොන හරි operation කරලා තියෙනවද? Have you undergone any previous operations? If so, if it's a major operation, so imagine the patient is saying, oh doctor පොඩි තුවාලයක් තිබ්බා, තුවාලේ මෙහුම් දැම්මා. Oh doctor පොඩි සැරගෙඩියක් තිබ්බා, සැරගෙඩිය පැලුවා. Right? Those things you don't need to elaborate. But imagine the patient said, oh doctor මගේ බඩ පැලුවා. බඩ බලලා operation එකක් කරා. Okay. Now little bit elaborate under what, probably under GA. any complications, ICU stay, what did they do in the laparotomy? You can ask that, right? Because that will be important in our management. And then other allergic history, කැම බීම ප්ලාස්ටර් වලට බෙහෙත් වලට allergic තියනවද? නැහැ. Family history. පවුලේ කට්ටියට මේ වගේ ලෙඩ රෝග තිබිලා තියෙනවද? පිත්තාශය ගල් තිබිලා අයින් කරලා තියෙනවද? පවුලේ කට්ටියට මේ have any of them had hemolytic anemias, right? ලේවල මේ මොන හරි ප්‍රශ්න තිබිලා තියෙනවද කියලා, right? And then drug history, whether the patient is on any kind of medications, right? Because those medications might be important when we are preparing the patient for surgery, right? For example, a patient on anticoagulants, we need to stop it. Patients on oral hypoglycemic agents before surgery, we have to stop it, right? And if the patient is started on antihypertensive recently, we should at least stay 2 weeks before we do the surgery, right? Because of that, we need to check the drug history and the social history, right? So this again, we don't have much time, so we should fast forward, right? For occupation, alcohol and smoking, support, family, we are doing a surgery, right? After surgery, does she have anybody to support her, right? Things like that. And at the end of all this discussion, you can again pitch an open question, right? Do you have any other things that I have not asked that you would like to say to me, right? And also, if you are happy, you can ask that questions about patients' ideas, concerns, and expectations here, right? Okay. Then we will go for now. In this situation, it's very unlikely they will ask you to examine the abdomen, right? Because it's 10 minutes time, you won't be able to examine the abdomen also, right? So, because of that, you don't need to worry much about that. But since this is a class about abdominal pain, I will just touch a little bit of abdominal examination also. So it gives you a comprehensive idea, right? But very unlikely you will have to do an abdominal examination in a patient. If so, the situation might come, take a very short history and do abdominal examination. For example, like a hernia, right? Something like a hernia, then you can't take a history. So in that case, take a small history and do the relevant examination. Did you get the idea? But imagine a case like biliary coli, where you have to take a detailed history. In the 10 minutes time, is not enough to do abdominal examination.
So what do you need in a short history compared to a detailed history?
In short history, for example, in inguinal hernia, what are the risk factors, right? Basically, smoking, coughing, straining, risk factors, right? Occupation, is this painful, right? And now imagine direct inguinal hernia, if it's not painful, we can just observe, right? So painful, his occupation, as I said earlier, things like that, right? Whether this is affecting his day-to-day life, things like that. We will discuss when it comes to inguinal hernia examination. We'll discuss about those also, right? So yeah. Now imagine a patient coming carpal tunnel syndrome. Just think, right? For example, which hand is dominant? Risk factors: diabetes, hypothyroidism, any fractures in the distal radius, right? Whether what is the occupation? Is his occupation affected? So those few questions to get a small idea. So small history, then go to the examination. In those things, examination is the main part. But in things like abdominal pain, we are focusing about the history taking mostly, right? Okay. So just to cover, we'll just cover the examination also, right?
Sir?
Yeah.
Sir, in like a history station, are we expected to represent the history to the examiner, or are they just observing and we are allowed to move on?
In a VIVA station, yes, but this is OSCE station of 10 minutes. 10 minutes to take the history and as well as answer the patient's concerns, right? So very unlikely you will be asked to, like in OSCE station, you won't be asked to summarize it. If anything, you can summarize it for the patient. Now, when you take our proper history, after you take a history, you have to summarize the history to the patient, right? It would be ideal if you can do it, but in this 10 minutes, I don't think it is possible to do that. right? It is possible if you are very fluent in an abdominal history taking, right? If you know what to take and you very fluent, yes, you might, but might be difficult. So taking history and presenting, no, just take the history and explain to the patient and formulate a management plan. This formulating the management plan could be a discussion, right? Okay, now you have explained to the patient, then the examiner might start, okay, what are you going to do next? Basically your clinical management skills, right? So I am going to I'm going to confirm the diagnosis with ultrasound scan abdomen to check the biliary calculi in the gallstone, in the gallbladder, as well as I want to assess the biliary tree for common biliary tract for dilatation and right? After that, I will, if indicated, I will do the liver profile test, full blood count, and other relevant investigation needed for now this 45-year-old female without any other comorbidities, then a full blood count will be enough, right? No need of ECG, no need of serum creatinine, electrolyte, anything, right? Okay. Okay, you're happy? Okay. So I will just a little bit discuss about examination of abdomen also, right? We will discuss the examination in a separate class where examination of all the systems are done. But just to give you a touch about what to examine, right? So when you're talking about examining a patient, before examination, there are few prerequisites that you should do, right? Basically, if you have now in this patient, we have already explain to the patient who you are and clarify the credentials, right? So you don't have to do it again, but you need to take consent, verbal consent for abdominal. So shall we go ahead and examine the abdomen? So she will say yes, right? And then we should make sure it's a proper setting, right? It should be a setting with adequate privacy, right? And it should be not a very cold room, right? Adequate temperature and adequate privacy, right? And we should ask for chaperone. We should ask for assistant for our examination, right? So we are going to expose this patient for particularly in abdominal examination. We are going to expose these patients vulnerable areas, right? So we should always have a assistant with us.
So
Right?
chaperone in both males and females or only females?
No, like chaperone is applied for everybody, female and male both. Even you are a female doctor, you can't examine a patient alone. You should have assistant, right? It could be another doctor. That is different. It could be a minor staff, it could be a doctor, it could be anybody. But you should have somebody else with you, right? For litigation purpose and everything, you should always have somebody else, especially not specially, but should be there in everything, but especially in examinations such as this, where the private areas are exposed, such as breast examination, abdominal examination, DRE, right? Per vaginal examination, those things are definitely you should have a chaperone, right? So then lighting, the setting should have natural type of lighting. So just saying that I would ensure these are available would be enough, right? No need to like I would ensure like I would ensure may I have a chaperone, may I have a adequate lighting, and then the bed, right? It should be a like a not really soft bed. It should be a little bit of a hard bed, right? So what happens if you examine the patient in a soft bed is the patient is basically buried in the bed and the lumbar lordosis is lost. So then it is difficult for us to examine the abdomen, right? And then the muscles will be also flexed and contracted, then difficult for us to examine. So it should be a bed that is a hard bed with the ability of elevating the head end at least 15 to 20 degrees, right? Okay, and the position, right? Supine position, and we can place a what do you call pillow over the head to flex the head, right? And if till the abdomen is tense, you can also flex the hip to release the abdominal wall, right? and then we expose the patient. So for abdominal examination, we should expose the patient from nipple region to the mid-thigh level, right? When you expose this region, you are basically your genital areas are exposed, right? Now, this is very embarrassing for the patient. So we, after exposing, we should make sure that patient's area is covered with a towel or a blanket, right? Up to the pubis symphysis. We expose the clothing from the nipple level to the mid-thigh level, but then we make sure we put a clothing or something, some blanket or something, or white sheet or something, to up to the patient's pubic level. If we need to go down, we expose that area when we need to go down, right? Did you understand? Okay. And one more important thing, always make sure you either use the hand sanitizer or you ask the surgeon or examiner, I would like to wash my hands first, right? Because touching a patient with dirty hands is actually considered as an insult to that patient, right? If you just touch a patient, now patient doesn't know where you have used this hand. You would have gone to the toilet, come out without washing your hands and coming and examining the patient, right? Can happen, right? So if you don't do that, it's highly insulting and it's not very hygienic also, right? But because of that, you should ask either hand rub or facilities to wash the hand. You don't have to wash the hand, but just asking is enough, right? Because washing hand will take time, right? Okay, and you should also make sure that before you palpate, you rub your hand a little bit to make it cold, warm, right? If you touch the patient with cold hand, it's a little bit uncomfortable, right? And where you should come? You should come from the patient's right hand side, right? Not from the left hand side, right hand side. All right. So that is how you make the setting to examine the patient. Before you examine, you have to do these things too. Did you understand? Okay. Then you all know the inspection and the examination pattern: inspection, palpation, percussion, and auscultation, right? Okay. So inspection of the abdomen, you should do from two ends, right? From the foot end of the bed and as well as the side of the bed, right? So from the foot end of the bed, you are from the foot end of the bed, you are looking at the patient's symmetricity, right? Symmetricity of the abdomen. For example, if there's a mass in the left side of the abdomen, that left side will be asymmetric compared to right side, right? Any symmetricity and symmetricity of the respiratory movements, right? If there's abdominal respiration movements, symmetricity, right? And then you come from the side of it and again examine like that. And then you examine from the top and you look for any distensions, any visible scars, any visible dilated vessels, right? And so on. Any accessories such as any peg tubes, ileostomy, stomas, any feeding jejunostomies, any suprapubic catheterization devices, any other devices that are available. So you examine. So you basically look what the patient's having, right? Basically inspect everything. Okay. And then we go into the palpation, right? So palpation, there are two parts: superficial palpation and deep palpation, right? And then organ palpation. Okay. So before you go into palpation, you should make sure you ask the patient, do you have pain? Right? If the patient is having pain, the patient, you should ask, is there any region in your body, in your abdomen, that you have in pain? Right? Imagine now the patient shows a epigastric region and go and say, doctor, I am having pain here. Right? Then when you manipulate that region, you should be extra careful not to cause pain. Right? If you are making the patient having pain when you examination, you should stop there. You should not proceed, right? And you should always start from an area that is not painful before you start the painful area, right? Oh, and one more thing, when you always palpate a patient, always look at the patient's face rather than the abdomen. one of the commonest mistake that most of us do is we forget the patient's face and we see where we are palpating, right? Then we will not pick up the subtle facial expression of the patient when the patient getting pain, and that would be a penalizing mark, right? Because you have not considered the patient's pain, right? Okay, so we start the superficial palpation while looking at the patient. After asking whether there are any painful areas, we start in an anti-clockwise manner, right? From the right hand, if you are right hand, what do you call it? If you are right hand person, start from the right, use the right hand, and we palpate from the entire palm, right? Not just the fingers, entire palm. We basically palpate the entire hand, right? Hand and the fingers, like basically entire. We do not flex the arm like this. We basically palpate like this, right? In an anti-clockwise direction, you can start from any area. Personally, I prefer to start from the left iliac fossa region if the pain is from the other area. So I start from there. I go to the left side flank, left hypochondrial region, epigastric, right hypochondrial region, right side flank, right side iliac fossa, suprapubic area, and then the central abdominal periumbilical region. So that is how I used to do. You can have your own way, that is fine. And then we basically assess in this whether the patient is having pain and whether we can feel any palpable masses, right? And if there's no palpable masses in the superficial abdominal examination, then we can go for the deep abdominal examination, right? But if the patient is having pain in the superficial abdominal examination, you are not going to proceed further. You can say the examiner, sir, the superficial palpation itself is causing this patient pain, so it is difficult for me to proceed further. I will abandon and not proceed further with the deep palpation and organ palpation, right? And you will not do the percussion also, because percussion also will be then painful, right? Okay. And then we check the deep palpation. If we detect any masses, we focus on that area first. Otherwise, we again go in the same region, right? Now we are actually putting pressure with our fingers, right? We basically putting pressure with our fingers and palpate, right? So our fingertips are the most sensitive, right? So we basically put pressure and palpate, right? Again in the anti-clockwise direction. And if we find a mass, what should you do? If you now imagine we find a mass. First of all, we should make sure that whether this mass is above the abdominal wall or below the abdominal wall. So if it's a below abdominal wall, it could be an intraperitoneal. If it's above abdominal wall, it could be something in the wall or in the subcutaneous tissue, something like what do you call lipoma or dermoid tumor in the muscles or hematoma in the muscles, or something in intraperitoneal region, something from the organs or anything, right? So for that, how do you discern? Can anybody tell me? So basically, we ask the patient to lift his head up, right? When the patient lifts his head up, the rectus abdominal muscle is going to tense. So if the mass disappears, where is it? It's intraperitoneal, right? Intra-abdominal. Because now we can't palpate. If it is outside, the mass will be more prominent, right? And then we look at the size, shape, mobility, surface, edge, consistency, fluid thrill, pulsatility, and dullness. We will discuss about these factors more in the examination lecture. And then we palpate for the liver, spleen, and the kidney, right? Again, we will discuss about the technique in the abdominal examination lecture, because it will take time, right? And then we move on to percussion, right? So percussion, we are checking for fluid dullness and shifting dullness, right? If we found any palpable mass, we should percuss that palpable mass to check fluid thrill dimensions, and also we can do this thing called suction flash, right? Basically, we imagine if we found there's a fluid thrill, we basically hold the patient from the two iliac anterior superior iliac spine and shake the patient, right? So think like container with water, you splash it, you get that jala jala sound. The same sound you will hear, right? Okay. And then we move on to auscultation. So basically the bowel sounds and the renal and aortic buoy. Those and the important thing is now your examination doesn't end there, right? You have not done the general examination, you have not done the hernial orifice examination, and you have not done the genitalia examination, DRE, and the vaginal examination, and also the supraclavicular lymph node examination, which is part of the general examination, right? So you should make sure that even though you don't, you can general examination you have to do, but DRE, vaginal examination, genital examination, you can offer to the examiner, I would like to perform these few to complete my examination, because without doing these examinations, your abdominal examination is not complete, right? So hernial orifices, the inguinal and the femoral is the commonest, and if there's any scar, then you have to check whether there's a hernial orifice. You can basically ask the patient to cough and see the expansile cough impulse, right? And basically ask the patient to lift his head up and lift the legs up. Then you can see whether there's a divarication of recti, right? And then we, in the general examination, we have to check for fever, pallor, jaundice, angular stomatitis, glossitis. It was a supraclavicular lymph nodes, Virchow's node. It was a clubbing, peripheral pulses, features of iron deficiency like Kylonoki and all, and then peripheral edema like ankle edema and all, right? So those things we should examine, right? Apart from that, we should definitely ask the patient, offer to check the testis, the scrotum and the penis. And in females, vaginal examination, DRE, vaginal examination, and both sexes, DRE should be offered to the examiner, right? Then only your abdominal examination is complete, right? So we'll discuss what to examine in DRE and all in the examination module, right? Okay. So then now we have come to a differential diagnosis or diagnosis. Now we have to explain to this patient what this patient has. Now the patient is asking, so doctor, what do you think I have? So you are going to explain to the patient in layman's term either your diagnosis or differential diagnosis. So then now our diagnosis biliary colic, right? So basically we can read ඔයාගේ පිත්තාශයේ ගල් වගේක් හටගෙන තියෙනවා. ඒ ගල් බ්ලොක් වුණාම තමයි මේ වගේ කැක්කුම එන්නේ. හරි? ඒ ගල් බ්ලොක් වුණාම තමයි මේ වගේ කැක්කුම එන්නේ. ඒකට then now then patient will ask, can ask why did I get gallstone? Then you can explain that there are risk factors: female, OCP, obesity, age, diet, and all those things, right? And one thing you should do is you should explain these terms in very layman terms, right? You should not use medical terms, right? You should know, like, imagine like you are talking about jaundice, you should not use jaundice as kahavenam, right? Like something like that. Okay. Then once you explain the diagnosis, what are you going to do next? You are going to explain to this patient, okay, now this is suspicion, now I need to confirm the diagnosis. For that, අපි බඩේ ස්කෑන් එකක් කරනවා. බඩේ ස්කෑන් එකක් කරලා ගල් තියනවාද කියලා බලනවා. ගල් තියනවා නම් අපි ඒකට කරන්න පුළුවන් මොකද කියලා ගල් තියනවා නම් now then next we will do the what are the treatment options available for this patient. Now when it comes to biliary colic, there are no other treatment options except laparoscopic cholecystectomy. So you explain this. මේකට කරන්න පුළුවන් එකම දේ තමයි අපිට පිත්තාශය ගල් හැදෙන්නේ පිත්තාශයේ. එතකොට අපි පිත්තාශය අයින් කරපුවාම ආයි ගල් හැදෙන්න හේතුවක් නැහැ. අපිට පිත්තාශය අයින් කරන එක තමයි කරන්න පුළුවන් එකම විසඳුම. අපි පිත්තාශයේ ගල් අයින් කරන්න නැතුව එහෙම තිබ්බොත් එහෙම ආයි දිගට මේ ප්‍රශ්නේ එනවා. Sometimes the patient might ask, අපිට ගල් විතරක් ගන්න පුළුවන්ද පිත්තාශය ඉතුරු කරලා කියලා. So basically then you have to say, we can't do that. අපිට එහෙම කරන්න බෑ. අපි එහෙම කරත් ආයි ඒකේ ගල් හැදෙනවා. අපි එහෙම කරත් ආයි ඒකේ ගල් හැදෙනවා. ඒකින්ද ඒ වැඩේ කරන්න බෑ අපිට. අපිට පිත්තාශයම අයින් කරන්න වෙනවා. Right? So basically we explain in layman's term. So I hope everybody understands Sinhala, right? Is anybody here that does not understand Sinhala? I forgot to ask that in the first. Is there anybody here who does not understand Sinhala? Okay, since nobody is answering, I will assume that everybody understand, right? Okay. Anyway, so in layman's term, either in Tamil or Sinhala, you should explain to this patient, right? And the patient might ask then, doctor, then when you do a laparoscopic cholecystectomy, what are the complications? When can I go home? When can I go back to work? So those things we need to answer in again layman's term. We'll come to those later, right? And as I mentioned earlier, patients' ideas, concerns, and expectations. This is called ICE, right? So basically, you have to entertain these. If you entertain these, that means you have answered the patient's questions, right? You have done the history taking, and you have to entertain the patient's ideas, concerns, and expectations. Okay. So as I mentioned earlier, the widest cholesterol occurs, right? So basically 80% cholesterol stones, stasis, supersaturation, and enucleation is the main factors, right? Okay. Now he might ask, okay, doctor, how do we investigate? So as you mentioned earlier, the basic investigations including full blood count, serum electrolyte, serum creatinine, ECG, INR, bilirubin levels. This INR, bilirubin levels, INR and ECG, they are serum creatinine, serum electrolyte is not necessary for this patient. Why? Because the patient is 45 years old and no history of any comorbid diseases, right? Now, these investigation including serum electrolyte, serum creatinine, ECG, 2D echo, chest X-ray, and all those are included. If the patient is more than 65 years, yes, then we have to do this. But otherwise, if it's less than 65 years and no comorbidities, then we don't have to do it unless indicated, right? But we have to do a liver profile test to check whether the patient's bilirubin levels. Why? Because if there's a CBD stone and causing obstruction, and we do a laparoscopic cholecystectomy, the patient is going to go into post cholecystectomy syndrome. That means patient is going to develop jaundice and may even develop cystic stump blowout and causing bilioma, right? So in that case, we should first of all do the ERCP, remove the stone, and do the laparoscopic cholecystectomy. If you can't remove the stone during the ERCP, what we can do is we can put a stent to relieve the obstruction, and then during the surgery we can do the CBD exploration, right? So those are the options. So we can explain that to the patient, right? Okay. So now we have our diagnosis confirmed. The management, first analgesics. Obviously, this patient is in pain. He might have pain before you go to the surgery, because you won't be doing the surgery straight then and there. You will be putting the patient to theater list, and this theater list will depend on how heavy in the unit. It will take some time, right? A month or 2 months or so. And then during that period, if the patient is having pain, you should give her analgesics, right? And advise her on consent her on the laparoscopic cholecystectomy, right? Okay. And also symptomatic treatment for nausea and vomiting, right? Okay. And if the patient is having acute cholecystitis, antibiotics. All right. So consenting for laparoscopic cholecystectomy. What do you know about that? Can anybody tell me something that you are going to tell to this patient during the laparoscopic cholecystectomy consenting?
Like normal explaining and everything, we have to make sure that they know that if a complication happens, it will be converted to open.
Okay, complications. Okay, what else? Okay, I will tell you. So, taking consent could come as a OSCE station for you, right? So basically, because you are the house officer, most of the time the consent will be taken by you, right? So you should be able to take a proper consent from a patient. So in order to do that, you should know what are you going to say to that patient when you take a consent, right? Okay. Okay. So this could come as a very well as a even as a single OSCE station, right? Because taking consent takes time, right? Because when you take a history and you can't take consent the same, taking consent might come as a separate communication station. Okay, you have this mnemonic called led to reason, right? Led to reason. You can see in this image slides. So what is L? Leading. Leading. That means you basically introduce yourself and confirm credentials, like that is lead in. Then E, explore. You explore what the patient knows about his condition. The patient might be knowing what his condition is. He might be knowing, okay, I am having biliary colic. I am having stones in my gallbladder, right? Or the patient might be totally oblivious, right? He has no idea, right? So explore what the patient knows about his condition. And then comes the diagnosis. If the patient doesn't know the diagnosis, we give the patient the diagnosis and explain what this is, right? So basically we are telling, you can't say Sia, you have to say by the name, right? So Mrs. Tushari, ඔයාගේ පිත්තාශය ගල් කටගෙන තියෙනවා. ගල් හැදෙන්නේ මෙහෙමයි. ඒ ගල් නිසා ඔයාගේ පිත්තාශයෙන් එන අර පිට එළියට එන එක බ්ලොක් වෙනවා. ඒ හින්දා තමයි ඔයාගේ මේ කැක්කුම තියෙන්නේ. ඒකට අපිට කරන්න තියෙන්නේ. So next then the T comes to a T, treatment. So what are the treatment? Recommended treatment by our side, right? What the treatment we recommend? So we recommend laparoscopic cholecystectomy. ඒක ඒ වෙනුවෙන් අපි ඔයාලට කරන්න පුළුවන් අපේ දේ තමයි ඔයාගේ කැමරාවක් ඇතුළට බඩ ඇතුළට කැමරා දාලා පිත්තාශය අයින් කරන එක. What are the other options? O means options. What are the other options? In this situation, no other options. But in other diseases, different diseases, there will be multiple options, right? There would be conservative options, there will be treatment option. But here only surgical option is available, right? So what are the other options available, right? And then we discuss the benefits and disadvantages of both options. Now imagine patient coming with peripheral vascular disease, right? We can offer the patient angioplasty and bypass, right? And then we can discuss on the advantages of bypass and the advantages of angioplasty, as well as disadvantages of angioplasty and disadvantages of bypass, right? That is options. And then the reason, R, the result. So what do we expect by doing this surgery? පිත්තාශය අයින් කරනවා පස්සේ ආයි ගල් හට ගන්න තැනක් නැහැ. එතකොට ඔයාගේ ආයි මේ ගල් වලින් එන ප්‍රශ්න නැති වෙලා යනවා. හරි? Results. Eventualities. So what is E? And then R is results. E is eventualities. Right? So what is eventualities? What happens if you don't do anything? If you don't intervene or don't do anything, what happens? So what's going to happen to this patient? The patient will keep getting pain, right? And at some point she will have acute cholecystitis. ඔයාට දිගටම කැක්කුම එනවා. කැක්කුම ඇවිල්ලා එක මොහොතක එක තැනකදී ඔයාගේ පිත්තාශයේ විස බීජ ගිහිල්ලා පිත්තාශය ඉදිමෙන්න ගන්න පුළුවන්. අනික හදිස්සියරි ඔයාගේ පිත්තාශයෙන් එළියට ගලක් පැනලා ගියොත් එහෙම ඒ ගල ගිහිල්ලා හිර වෙලා ඔයාගේ පිතනාලා බ්ලොක් වෙලා ඔයාට අමාරු වෙන්න පුළුවන්. විස බීජය ගිහිල්ලා උණ ගලන් අමාරු වෙන්න පුළුවන්. සමහර විට පිත්තාශයේ ඔය ගල ගිහිල්ලා අඥාසය අඥාසයේ එන්සයිම් එළියට එන තැන බ්ලොක් වුණොත් එහෙම අඥාසය නරක වෙන්නත් පුළුවන්. So those are the eventualities, right? So basically pancreatic acute pancreatitis, gallstone pancreatitis, CBD obstruction and obstructive jaundice, recurrent biliary colics, causing pain and discomfort, as well as acute cholecystitis, acute and chronic cholecystitis, right? Okay. So that is the eventualities. And A, adverse effects. So the complications that Nipun is told, right? So when you talk about complications, you can categorize this complication into 3 broad categories. Any surgery, right? Basically, anesthesia complications, right? If you are going for any type of procedure, you will be giving anesthesia, either local, GA, regional blocks, anything. What are the complications of those? So example, this will be done on general anesthesia. So general anesthesia, the patient will be having, will be intubated, right? So once is intubated, the patient might have difficult intubation and might need ICU care, right? And after general anesthesia, the patient might develop malignant hypothermia, electrolyte disturbances, right? Anaphylaxis, allergic reactions to drugs, right? All this can occur, right? Okay. Yeah, that is anesthesia. And then when you come to surgery, it can again divide into specific for this surgery and common for all surgeries, right? Bleeding and infection is common for all surgeries, right? For any surgery, bleeding and infection is common. But for this surgery itself, what are the common? Iatrogenic biliary tract damage, IBD, right? Iatrogenic biliary tract damage to surrounding organs such as liver bed, duodenum, stomach, right? Those things, right? So specific complications of the surgery, and then comes the post-operative complications, right? So what are the post-operative complications? Again, surgical site infection, bleeding, right? Apart from that, post-cholecystectomy syndrome, iatrogenic biliary tract injury and causing leak, right? Causing biliomas, right? So, and if there's a concomitant CBD stone or slipped stone, it can cause obstructive jaundice and cause post-cholecystectomy syndrome, right? So those are the complications of the post-operative complications. If you classify like that, you don't have to tell all these complications. If you just classify and tell few complications, then the examiner knows that you know these things. The fact that you are able to classify something and shows a lot about you. It shows that you are a methodical person who assesses a patient methodically. If you just keep telling, okay, after surgery you will get bleeding and pain, bleeding and infection and move on, then that is then I'm not saying you will not pass, but the amount of marks you get is low, right? So you can categorize and tell anesthesia, intraoperative and postoperative. Intraoperative, common for any surgery, common for this surgery, specific for this surgery, right? Okay, that is A. And what is S? Now we have explained everything, right? Now I have explained to Sankar in German something. Sankar notes and keep nodding, right? So am I to assume that he understand? He might not be fluent in German, right? So whatever I is saying, he might be nodding because he's embarrassed to say that he doesn't know it. So he will be nodding, right? But he doesn't understand. So we should make sure the patient did understand. So S is sound mind, whether the patient did understand what we said. So we basically can ask few cross questions to check, right? Few cross questions out of all the things we have explained him. We can ask few cross questions, right? Okay. And O, what is O? Again, open question. Basically, we can ask a question. Do you have any other questions you need to ask me? which I have not asked you earlier, right? So imagine the patient has been worrying through the entire process. When can I go back to, he's the sole breadwinner of the house. Imagine a three-wheel driver. He's the only person working. He has a family of 3 children and 1 wife to support, right? If he doesn't go to work as soon as possible, then the wife might have to sell her chain, right? So so his main question is, when can I go back to work? So we might not pick it up if we don't ask that question. So any other question that you might want to ask him, right? That is O, right? And N is called notes. Then at the end, you can't just sign. It's kind of like awkward. So you should have a like a polite and nice way of asking. Okay, now shall we get together and note down everything that we discuss, and shall we sign the document? Something like that, right? It's like a nice way of asking, can you sign this document then, right? So that is how you take a consent. Led to reason, right? Though you remember this mnemonic by heart, so you can, if you are given this thing, then you can obviously tackle it, right? So getting consent, there is a very high chance that you can get a OSCE station like this, right? Taking consent. Believe me, even if it doesn't come in this exam, at least in the next exam, it will come, right? Okay. We will have a class on communication, right? For how to communicate with patient, how to communicate with peers, how to communicate with, how to break a bad news, right? And all those things. We'll have another class, right? So, okay. So, and another thing, they can ask you about the preoperative preparations. So those are another few areas that they can ask you again. So how do you prepare a patient for surgery, right? So basically, consent, you can admit the day before. In some centers, you can do this as a day case basis also, but most of the time it is done not as day case surgery. So day case surgery is when the patient admits on the same day, surgery happens on the same day, and discharged on the same day. That is called a day case surgery, right? But some laparoscopic policy can be done as day case surgery, but usually in our country it is done and not as a day case surgery. Then optimize any comorbidities. If the patient is having comorbidity, optimize it. If the patient is having diabetes mellitus, make sure her HbA1c is less than 8.5, right? Make sure the blood glucose level before going to surgery is between 120 to 180, right? Whether the patient is having an oral hypoglycemic agents, based on those, we have to adjust and omit some oral hypoglycemic agents based on the type of surgery and based on the meals he's going to miss before the surgery, right? And whether the patient is hypertension, is the hypertension under control? Is there any drug started recently? Is this drug started 2 weeks before or later, right? And if the patient has ischemic heart disease, we have to assess the patient's 2D echo and assess the patient's heart functionality, ejection fraction and all. And if the patient is on anticoagulants, we have to stop the anticoagulants. Clopidogrel at least 5 days, warfarin at least another 5 days, aspirin. You can continue only, if it is only aspirin, you can continue on. But if it's dual anti-beta therapy, at least we have to take off the clopidogrel. If you want to take off aspirin also, at least 7 days, it should be off, right? And anesthesia referral for pre-medication before the surgery, and the anesthesia team will review the patient. And the basic investigations, full blood count, RFT, LFT, ECG, coagulation profiles, and all these things are not indicated if the patient is less than 65 without any comorbidities, right? And grouping and DT, if we are expecting more than 500 ml of blood loss, grouping and DT, 2D echo and chest X-ray if it's indicated, urine, especially in females, right? You should ideal do a urine HCG before the patient goes into surgery, right? Most of the time this does not happen in the wards, but this should be happening, right? in UK and all, this is a must because of the litigation problems and all. So urine HCG in a female patient in childbearing age is a must, right? And HbA1c if the patient is having diabetes. 6 hours fasting for solids, 2 hours for clear fluids. So what is clear fluids? Only water, transparent fluids, right? Water, just tambili, jeevani, plain tea, those, right? Ensure the patient is not on anticoagulants. Ensure adequate hydration. Adequate hydration doesn't mean the patient should need to be in IV fluids, right? It could be oral fluids. No need to start on IV fluids unless indicated, right? Arrange priority on the theory list based on comorbidities. If it's a patient with diabetes, then the patient needs priority in the list. Should be gone as a first case, right? If it's a small child, then again priority should be given, right? And based on the day of the surgery. Before going to theater, the patient should bathe and come, right? So that is how you pre-operatively prepare a patient as a house office. So these things they might be able to ask you, right? Okay, this is ASA1 ASA classification, right? How to classify patients based on their comorbidities, right? You can leisurely read on this. Okay, now the surgery has been done. Patient comes back to the ward. What are you going to do? So, the consultant has done the surgery. Now the patient is back in the ward after recovery. The first thing that you are going to do after coming to surgery, after theater, after the ward, what are you going to do? You should take the post-operative operative note. What has happened? Was the surgery a routine one or was it complicated? Right? Surgery can get complicated, right? So if it's a routine one, good. It's a complicated one, then you need to read the post-op recommendations and stick to those, right? And monitor the patient, connect the patient to a monitor, check the blood pressure, respiratory rate, saturation, pulse rate, urine output, and temperature, right? And then monitor that in the news chart. So this is the news chart, NEWS chart, right? Have you seen this before? Have you heard about this before? So there's a news chart, right? So basically this is a tool used to assess patients, right? We can assess patients based on few parameters. So it's very neatly done, right? A, B, C, D. So A and B is airway and breathing. C is circulation and D is disability and neurology, right? And E is temperature, right? So first A is respiration, respiratory rate. B is saturation. Then whether the patient is on oxygen or not. C is blood pressure. C again, another C is pulse. D is alert, verbal, alert, vocalization, and ABPU, right? And unconscious patient and responding. And then E is for temperature, right? So based on these, now you see they are color coded, right? Because based on this color code, you get marks. And based on these marks, you will assign the patient into risk group. Based on the risk group, our escalation of the management and is determined whether this patient needs to go in, whether based on these scores, we decide whether this patient need to be informed to the consultant or the medical officer by the nursing team. And based on this, we decide whether this patient need to be escalated the care into HDU, ICU or so, right? Okay, news chart also very important, right? And then analgesia, continue antibiotics as indicated. If it is prophylactic antibiotics, then no need to continue. But if it is therapeutic antibiotics, then need to continue as indicated. Start oral feeds as indicated. Some surgeries, early feeding is indicated. Some surgeries, early feeding is not indicated, depending on the surgery. Depends. For example, for laparoscopic cholecystectomy, if it is uncomplicated, yes, early feeding as soon as possible. As soon as the patient recovers, early feeding. And observe for complications. Anesthesia complications, common for any surgical procedure or common to the specific procedure, right? That is the post-operative care. And finally, discharge. So how do you write a discharge? So writing a discharge card could come, could not come. There's no harm of knowing it, right? Sometimes they can give a diagnosis card and ask you to write it down, right? So basically those are duties of house officer, right? So basically they are checking there you are safe to do a house officer work, so can come, right? So how do you write a diagnosis card? Have you seen the diagnosis template of the diagnosis card in Sri Lankan healthcare sector? No, right? Okay. I will in the next lecture I will show you a template of it, right? I'll take some photos and show you. So basically, in the first page you write patient details, right? Name, age, DHT, which ward the patient was managed, under which consultant, name of the house officer or the discharge, comorbidities, past surgical history, allergic history, and the diagnosis, right? Diagnosis is the red color. So, for example, diagnosis would be for this patient is laparoscopic cholecystectomy, right? Okay. Then in the inside page, you have a section to write the patient's history, right? So the presenting for the history of the patient is right hypochondrial pain for 3 months associated with spicy food, right? Risk factors, you can determine, you can put down risk factors and you can put the examination findings, right? And then the laboratory results, the full blood count results, the LFT results, and now, right? Then the treatment that we had, the surgical treatment as well as the medical treatments. So we must have given analgesics and antibiotics and know how long they have the antibiotics given, what analgesics they have given. If any allergies occurred, you have to document these allergies in red color, right? And the operative note. It's very important that you write the operative note properly. And and writing an op note in the theater is also part of it's a house officer work, right? So how to write op note also we should know. We'll talk about that also during lecture on medical duties, right? Okay. Yeah, op note and the medications, and then whether there was any complications. If there's no complication, good. But there's any complications, then you have to document what the complication was, what we did for that complication, any intervention, and how to follow up with that complication, right? And then the discharge plan. Now we have done a laparoscopic cholecystectomy. We have sent the gallbladder for histology. We should obviously review this histology, right? And we have done a surgery. There will be sutures in the laparoscopic surgery side. So we have to remove these sutures, right? So for that, we have to get down this patient in 2 weeks' time to remove sutures as well as to trace the histology, right? And as well as patient's discharge plan, right? Whether the patient needs to go home on antibiotics, whether the patient needs to go home on analgesics, right? And we should educate the patient when the patient can bathe, when the patient can go to work, when the patient can drink and go to normal day. So when can the patient bathe? After surgery. If now, for example, laparoscopy, after 2 days, the patient can remove the resins and bathe, right? So usually after suturing, after 2 days, you can bathe, right? So if sometimes the patient might ask this, Dr. So 2 days, right? Because the scab forms and epithelialization begins, epithelialization completes in 2 days. Once that happens, the chance of bacteria going in is less. That's why, right? And he can go into work whenever he feels fit, right? He can have a normal day-to-day. He can do the normal day-to-day activities. He can do the he can eat his normal day-to-day food, right? Those things, and the follow-up plan, as I mentioned. So that is a holistic approach to biliary colic. From the point where the patient came to you until the patient, you discharge the patient. Did you understand, or are there any doubts? So, in this OSCE, out of all these things, in this OSCE station, what is important for you is for this situation, the history taking, right? summarize history taking, not focusing on everyone, focused history taking based on the complaint, right? And then explain to the patient, formulate a diagnosis plan, and explain that to the patient. Diagnosis and management plan, explain that is your task in this OSCE station. Did you understand? Okay. Yeah, that's it. So you have not exposed to histories. So because of that, this lecture I explained you, right? But in the coming lectures, we will shift our teaching method to you asking me questions and I being the patient and you taking history from me, right? Now you are just, this is the first class. I'm not sure whether you are very exposed to proper history taking methods. So because of that, I explained this on my own, but from the next classes, we will shift a little bit towards me being a patient and you taking history from me, right? Is it good? Okay, good. All right, any questions? Anybody have any questions? So only Sank and Nipuni spoke. If anybody have any questions, please ask now. Anybody? Sharon, Girindu, Tiloka, Jaya, anybody?
Okay, I think everything is clear.
Sorry.
I think everything is clear. Thank you.
Okay, good. Let's see whether any comments over there. No comment. If you have any question, you can, if you are a little bit shy to speak, you can comment in the group. So when you are now, one other thing in this OSCE is you should let go of this fear of speaking, right? Fear of speaking and this shyness, this has to go. With this OSCE is difficult to do, right? Because for example, now imagine now you will be going to hospitals to take history and all, right? At one point, is it so? You have, right? So with this shyness and all, you can't do that, right? So be straightforward and speak if you have anything to ask, right? Okay. So you are now you are you aware about the history now? Now we took a biliary colic history, but taking a history format is common for any case, right? So now are you familiar with that history format, right? You basically we analyze we take what the presenting complaint and we analyze it, right? And if there's any associated symptoms, we analyze those also. And then we move on to differential diagnosis. And we ask few questions to entertain each of our differential diagnosis. And then based on those differential diagnosis, we ask risk factors and etiology, right? After that, we go ahead to complications, right? Yeah, complications, and then what happened up to now, what investigation, what treatment, what interventions, right? All those. And if you want, you can ask it here, the ICE, patient's ideas, concepts, and expectations, or you can ask it at the end also. That's fine, depending on how you like. And you can put an open-ended question whether you want to tell something that I have not asked regarding your disease, right? And then you move into systematic review. So that's the next part of the history. Now you have taken the history of the presenting complaint and everything. Acute history you have taken. Now you are going to check the patient's general well-being, right? Systematic review and past medical history, right? So systematic review, we all again take a focus depending on our history. We don't take each and everything, right? For example, biliary colic, there's no point of asking musculoskeletal disorders, right? Osteoarthritis and all, there's no point, right? And then, but for gastritis, yes, you understand the relation, right? Because NSAID use might be there. So yes, might have to ask. So, and then we move into past medical history, right? So basically you run through the diseases, common diseases. Do you have diabetes, diabetes, සීනි pressure, පොපේ අමාරු, අංශභාගයේ වක්කඩ අමාරු, දියවැඩිය, මේ සීනි cholesterol තියෙනවා. එකක් අර තියෙනවා කියලා කිව්වොත්, then you ask a little bit on more on those, right? And then whether any ICU admissions and past admissions very simply. And then past surgical history, and then family history, allergic history, drug history, and social history. Social history, don't go into town asking married, ළමයි කී දෙනෙක් ඉන්නවද, ළඟ තියෙන ස්පිරිතාලේ කොහෙද, like don't go into town. Basically keep it simple because you don't have much time. So basically ask about alcohol and smoking, occupation, and support, right? And if you really think the patient might need acute care, then you can ask whether there's a nearby hospital in your home or at your home, to your home, right? So, and then that brings an end to the history taking. Then at the end, you ask patients ideas, concepts, concerns, and expectations. What does the patient think about the disease? His disease is the ideas. He might have a diagnosis on his own, right? And concerns. What is the patient's concerns? Whether this is cancer, whether this will affect my day-to-day life, right? Whether my children also will have the same disease. Those things they can ask, right? Those are the concerns the patient asks. No matter what we explain, the patient is thinking, okay, this is that, right? If we don't entertain that, whatever we say, that patient won't understand. And the expectations. What does the patient want from us? Whether surgical management, whether the patient prefers surgical management or non-surgical management, or just patient want to watch and wait. Right? So that is and you finish the history with the open-ended question. Anything you want to let me know before we conclude the history taking. Are you clear? Are you clear and with this history taking? Okay, good. So what you can do is, when you're taking a history, always take according to this format. When you keep taking history, it becomes bread and butter, right? Then this format sticks in your head, and you don't need to artificially think about it when you go into the exam, right? 10 minutes is a very small time. It will go like this, and if you have to think and answer there, then you will get stuck, right? So taking more and more history is very important, right? It's all about for VIVA. So OSCE, they are not going to check your knowledge, as I said earlier. They are going to check your skill, right? So a skill develops when you work on it. If you keep working on it, your skill is going to develop, right? But if you don't work on it, that skill is going to be blunt. But if you are very smart, you might be able to tackle it. But imagine a not smart person working hard, he will be able to best that smart one with hard working, because skills are not born with, you are taught with, right? Okay. All right then. So that's it for today then. If you have any questions. All right then. Shall we conclude the session?
Thank you, sir. Good night, sir.
Okay. All right. Okay. Good night then. Bye-bye.
Thank you, sir. Good night.